Why is healthcare treated like a privilege instead of survival? If healthcare saves lives, why can't everyone access it? A person collapses at work, not from an accident, not from violence, from a medical condition that is treatable. Emergency services arrive, care is provided, the person survives. Weeks later, a bill arrives. It is larger than their savings, larger than their annual rent, larger than what many people earn in a year. The care worked, the system functioned, the patient lived, and yet the outcome is financial devastation. This is not a rare story. It is not a hypothetical scenario. It is not an exception. It is routine, which raises a quiet question. Why is healthcare treated like a privilege instead of survival? Healthcare refers to services designed to diagnose, treat, and prevent illness or injury. These services include doctor visits, emergency care, medications, surgeries, mental health treatment, long-term disease management. In many systems, healthcare is not automatically accessible. Access often depends on employment status, insurance coverage, income level, geographic location, legal eligibility. In some countries, healthcare is publicly funded and universally available. In others, it is largely purchased, often through private insurance. In those systems, medical care can be delayed, denied, or provided at extreme personal cost. Millions of people remain uninsured or underinsured. Others technically have coverage, yet still cannot afford care. This affects children, working adults, elderly populations, people with disabilities, people with chronic illness. The issue is not whether care exists. The issue is whether survival requires permission. Place these facts side by side. Fact 1, medical technology has never been more advanced. Diseases once considered fatal are now manageable. Surgeries once impossible are now routine. Life expectancy has increased due to medical innovation. Fact 2, medical debt is one of the leading causes of personal bankruptcy in several developed nations. People with insurance still accumulate debt. People without insurance avoid care altogether. Fact 3, emergency rooms are legally required to stabilize patients. But stabilization does not mean treatment, and it does not mean affordability. Fact 4, preventive care is consistently shown to reduce long-term costs, yet preventive services are often inaccessible to those most at risk. Fact 5, healthcare workers are trained to save lives, not assess creditworthiness, and yet billing departments operate alongside emergency rooms. Treatment first, payment later. These facts are rarely presented together, but together they form a contradiction. A system capable of preserving life that financially punishes those who need it most. Consider documented outcomes, not anecdotes. People delay seeking care due to cost concerns. Minor conditions become emergencies. Manageable illnesses become chronic. Preventable deaths occur. Medical debt impacts more than finances. It affects housing stability, credit access, employment opportunities, mental health, family planning. Patients report rationing medication, skipping follow-up visits, avoiding diagnostics. Healthcare workers report treating advanced cases that could have been prevented. Hospitals absorb unpaid costs. Costs are redistributed. Prices increase. The system cycles. Illness creates debt. Debt creates stress. Stress worsens health. No villain is required for this to happen. The structure alone is enough. This is not an accusation. It is an observation. Healthcare systems involve many participants: patients, providers, insurers, pharmaceutical companies, hospitals, employers. Some entities generate revenue when care is provided. Others profit when care is denied. Patients carry risk. Insurers manage risk. Providers navigate reimbursement rules. Employment-based coverage ties health to job stability. Losing a job can mean losing care. Getting sick can mean losing a job. Those with stable income access care earlier. Those without often access care later at higher cost. The question is not who is good or bad. The question is whether the system rewards health or manages illness. Healthcare was not always structured this way. In many regions, modern healthcare financing expanded during industrialization. Employer-based insurance emerged as a benefit, not a guarantee. It was designed to attract workers, not to ensure universal survival. Over time, systems grew complex, costs rose, administration expanded, access fragmented. What began as a solution to workforce needs became a gatekeeper to care. The system adapted, but the foundation remained. Healthcare as a benefit, not a baseline. At this point, the facts are clear. Healthcare exists, the knowledge exists, the technology exists, and yet access depends on circumstances unrelated to health. income, employment, coverage, timing. A person can do everything right, work full time, follow the rules, pay premiums, and still face financial ruin for getting sick. So the question remains, why is healthcare treated like a privilege instead of survival? Is this the result of oversight or design? Is it a necessary trade-off or a normalized contradiction? If healthcare saves lives, why does access depend on anything other than need? No opinions were given in this video, only documented patterns, only observable outcomes. The answer was not provided. The answer belongs to you. What do you think explains this?